Our last patient is a 76-year-old lady with underlying hypertension and stage renal failure on CAPD, presented to us with parectal bleeding. A colonoscopy was largely unremarkable apart from a 6 millimeter ascending colonic polyp and grade 4 hemorrhoids. An OGD was performed in October, and it showed a 1.5 centimeter mucosal thickening over the greater curve, with the biopsy demonstrating low-grade glandular dysplasia. So here we have the endoscopic images. And today we'll be performing a magnifying narrowband imaging OGD and endoscopic submucosal dissection.
Yeah, so I'm here with Professor Yao. So as you have listened to the history, this patient had a lesion found in the greater curvature of the stomach. So before we start focusing on one lesion, it's very important that we have to screen the entire stomach. So that's what we have been doing just now for screening for any other pathology in the stomach. So so far we only found this lesion located in the distal greater curvature. So Professor Yao, what's your opinion on this lesion?
So at a glance, this is very, very located, and this surface shows quite smooth,
Yes.
and that means regular. So at a glance, it looks like low-grade dysplasia, low-grade adenoma. But we need to think about the possibility of equal or more than high-grade dysplasia, because the color shows a slight redness.
Yes.
This is not so typical finding for low-grade adenoma.
So usually low-grade are whitish, more pale color lesion.
Yes. So we need to think about such things. So this is narrowband imaging, as you know. So we need to touch the tip of the hood very carefully. And this is the maximal magnification. If you get maximal magnification, this is water immersion technique. I'm inserting the water.
Yes, beautiful image. So we should focus on the demarcation between normal and abnormal mucosa, or a demarcation line.
And in addition, we can see the very, very circular marginal cryptophysium.
Yes, yes.
So that can be papillary structure in histological specimen.
Yes, yes.
That means this is more than low-grade dysplasia. In addition, of course, the central part shows as somewhat influenced by biopsy, but microvascular pattern at the edge shows more irregular than low-grade adenoma.
Yes.
But main part shows are quite compatible with low-grade adenoma.
So it's important to assess the entire lesion to look for possible areas that may harbor high-grade changes.
So this thing, so if you look at marginal epithelium alone, it looks quite regular. But when you look at the subepithelial microvascular pattern, the independent microvascular pattern shows a little bit irregular.
Irregular, yes, yes.
So I think this is not simply low-grade adenoma. So we need to think about different histology. So it's worthwhile to treat. So this is just oral side. As you can see, the marginal cryptophysium shows quite heterogeneous in this part.
Yes.
In addition, irregular microvascular pattern shows a little bit irregular.
Yes, yes, yes.
I think it's high-grade dysplasia, or in Japan, maybe
intramucosal cancer?
Yes, very well differentiated cancer. So rather than just low-grade adenoma. So as you can see, if you use water immersion technique, it can cancel halation, reflectance of the light. It can give us clear information, even though at maximal magnification. So it's very useful to obtain precise information.
Yes.
So this is what we assess by magnifying endoscopy. it's worthwhile to treat it. Okay.
Yes.
So are there any questions from the audience?
Any question from the audience for Professor Yao in terms of
Can you
diagnosis?
summarize a little bit? So you think this is a cancer?
Yes, high-grade dysplasia or cancer.
Based on the demarcation line in the middle and also the vessels in the abnormal vessels in the middle.
Oh yes, so demarcation line is present at the edge, this part. However, if you look at merged cryptoepithelium, so it shows regular. However, microvascular pattern is a more important finding for assessing the epithelial neoplasia. I think this microvascular pattern is rather irregular. This is not compatible with low-grade adenoma. So
do you think any additional staining like acetic acid or indigo carmine is helpful, or it's just enough using NVI?
There is no additional effect to this finding. So if you spray acetic acid, you can't assess microvascular pattern, which is more sensitive and specific for the diagnosis. So this should be enough, and there is no additional method so far.
So go on to resect with ESD, or this is quite small, right? So you can, in theory, do it with just an EMR.
I think both methods are okay, but today we're going to do ESD for this case. We want to get a good margin for day 3 pathology discussion. It will be interesting to correlate the endoscopic findings with the final histology findings when we discuss with our pathologists.
Okay, yes, we'll allow you to set it up. We'll go back to room.
So I'm going to put markings just around the epithelial region. So the point is, so it's quite easy to make marking, but what we need to think about is, so we need to compare histological specimen with endoscopic finding. So for such purposes, I always make effort to put marking in order to show orientation. So such as in order to show some landmark. So patient is coughing now, so just a moment, please. So if we resect the lesion, we don't know the orientation. So, but in order to avoid such inconvenience, I always put marking together, very close. So this is the orientation marking, this one.
So additional mark placed in the oral side.
So if we'd like to know very narrow space in order to compare the histological specimen, we always put just the edge of the lesion, additional marking. So between the 2 marks, we exactly cut the specimen and make the section. So it can tell us 1-to-1 correlation. So it is another idea. But this region does not need such close correlation. This is why I put 2 markings on the oral side.
Okay. So yes, so now we will change to a therapeutic scope and do the ESD afterwards. Today I'm going to do the ESD with a combination of dual knife and the IT2 knife. So the IT2 knife actually may help with a quicker procedure because the cutting surface is larger than the usual needle type knife. But of course, the needle type knife is very important when you do colonic or when you do esophageal ESDs. So we'll start from injection. So in the lesion that are located distally, so you can always start the dissection from oral side to anal side because the gravity will automatically helps you to elevate the lesion and create the traction that you need. Okay, needle out. Inject. More.
So Honchi, which solution are you injecting?
Actually, I'm using a mixture of saline and indigo, not indigo, just adrenaline and also with hyaluronic acid. Needle out. So I'm not using dye. So I think in my practice, I don't necessarily add dye in every of my ESD cases because Sometimes with dye, if it's too dark in color, it may obscure the vessel. So, so I would rather use, most of the time, I would rather use no dye for the procedure. Okay. 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 Dual knife. So now I'll use the dual knife to make the first incision, and then we can complete the mucosal incision with the use of the IT2 knife. So when doing mucosal incision, the first mucosal incision is usually done by a cutting current. So the cutting current have less coagulating effect. So it's important that we should not cut too deep. Otherwise, it will end up with bleeding if there are vessels in the deeper submucosal layer. So just a superficial cut is enough. Okay, IT2. So using the IT2 knife, so you can always cut from distal to proximal. So it's by a gradual dragging maneuver. So you can see how marking is important, because the marking actually helps you to see where you should be cutting next. So that's why Professor Yao indeed makes the marking very close to each other. So it makes my procedure much easier. So I know the direction of my cutting that I should cut afterwards. Yes, yes. So it's cutting from far side to near side. So I will check, the patient is coughing a bit. So I will check the margin. So this is the marking that we put intentionally in order to get more orientation. So I'll include this into my final specimen. Okay. Okay. And then we'll complete, I think we can complete the mucosal incision on this side now. So it's not too effective to cut that side, so I'll cut that later.
Hey Chi, would you have considered to use one knife, like a dual knife jet?
Yeah, indeed, yes. It's probably more cost effective if you use only one knife. So, but to me, I think I use both, because if you use the IT2 in the stomach, indeed, when you cut deeper, you'll find that it's quicker. So one method to reduce the cost is that during the initial mucosal incision, you only use a needle knife, but not the commercially available ESD special knives. So then you can save the cost of using 2 knives. So now I'm trying to deepen my mucosal incision so that I can get down deeper to the deeper layer of the mucosal incision, where I can actually see the muscularis propria. 出返到 So this procedure is what we call trimming. So after trimming, you would theoretically be able to see 2 separated mucosal incision with a better view of the muscularis propria layer.
What current right now are you using for your dissection?
Pardon?
What current are you using?
I'm using for force coagulation 480. So the current that you use for the IT2 knife is actually higher than that of using the usual needle type of knife. Dual knife. 出到
Time is 12:30. Lunch is being served outside. So we'll leave the transmission on the screen, and you're welcome to come in and watch, and after a meal outside.
Yeah.
Thank you very much.
Injection.
Okay, thank you.
Thank you.
We are breaking for lunch.
Okay, thank you.